So tonight we have three clinician experts joining us to explore how Canadian-made AI tools are changing the way that we deliver care today and what this means for the future of medicine. I'd like to introduce Dr. Mohammed Mamdani, one of Canada's most influential voices in AI and medicine and co-creator of ChartWatch, an artificial intelligence early warning system. This tool has shown remarkable results in a pilot program at Toronto St. Michael's Hospital, supporting a 26% drop in the number of unexpected deaths amongst hospitalized patients. Further, one of the AI tools he's going to talk to us about has reduced the number of patients with significant disabilities after stroke from about 84% down to about 52%. Next, we're also pleased to welcome Dr. Mike Weldon, an emergency medicine physician and electrical engineer from right here in Red Deer, Alberta, whose work with digital scribes is fighting burnout and reshaping clinical workflows. And finally, I'm pleased to introduce Dr. Jake Hayward, another emergency physician and clinician scientist from Edmonton. Since November 2024, he's led a 2-year pilot project of Dr. Weldon's AI scribe tool Jenkins and Alberta's emergency departments. This smart application records doctor-patient conversations and automatically generates medical notes, freeing up physicians to spend more time with patients and less time on paperwork. So with that being said, I'd like to hand it over to Dr. Mohammed Mamdani from Toronto, Ontario, who will tell us about the AI tools that he's created and that are being used in hospitals today. Dr. Mamdani, take it away.
Great. Thank you very much. It's a pleasure to be here. And I know we've got very limited time, so I'll try and be fairly quick. All right, so here we go. First, I wanted to start off with some basics around definitions. There are lots of definitions of AI, but I wanted to level set. Here's one definition: any technique that enables machines to mimic human behavior. So let that sink in a little bit. Basically, it's using machines to do what we do, basically. Machine learning is a subset of AI. Now, what machine learning does is it gives a lot more autonomy to machines. So if people remember their statistics courses, I know some people are traumatized by them, but if you remember when you were taught on how to build a regression model, you would have a lot of control and say over it. So you'd be able to pick your independent, your dependent variables. You'd be able to build in correlations, interaction terms, all of that sort of stuff. So there's a lot of human-guided guidance involved. Whereas with machine learning, it's largely saying, let the machines figure it out on their own. So the machines will figure it out on their own, and they'll let you know when they're done. What's deep learning? Deep learning is a subset of machine learning, basically more data, more complexity. For those who are familiar with neural network architecture, it's more hidden layers and such. It's more complexity. So all three are related. One is a subset of the other. But kind of my own personal sense in terms of how to understand this sort of stuff is it's about computers using data and math to understand the world. Because if you think about how we function as humans, that's how we function, right? With our five senses, we're constantly ingesting data. We're processing it in our heads, and we're coming up with thoughts, reactions, emotions, and such. That's basically what a computer's trying to do. This is ingesting data to understand the world. There are three broad types that I'd actually like to kind of expand on a little bit. One is generative AI. This is the ChatGPT and the DeepSeeks of the world. I'm sure a lot of you have heard about it and have interacted with it. It's basically when computers use existing data to generate new data. So when you're actually prompting or putting in a question to ChatGPT, it's actually leveraging all the data on the web and such to generate an answer for you. So it generates something. What's multimodal AI? If you think about our five senses, how we use data from what we see, hear, touch, taste, smell, similar to what computers do, right? You can throw in medical images. What if you add auditory data through scribes? What if you add lab data? What if you add vision data? So it's using different types of data to, again, understand the world. What's agentic AI? That's where things get scary, where the computers or the machines actually start doing stuff for you on your behalf. So for example, you can tell a computer, I feel like going to London this weekend. And of course, it'll say, all right, well, how many days? You'll say, let's go for 3 days. So it'll actually book your tickets for you. It'll book the hotel, set up your itinerary. It'll do all that for you on your behalf. Of course, with AI nowadays, you'll probably end up in London, Ontario, but that's a whole other story. But it takes actions on your behalf. So, for example, you could actually have an agent ordering an X-ray for you so the patient doesn't have to wait yet another 3, 4, 5 hours before they see an emergency medicine physician who initially said, hey, I know you've waited 3, 4, 5 hours. You need an X-ray. Let's wait another 3, 4, 5 hours before you get one. But of course, lots of things can go wrong, and that's why we're a little bit nervous about agentic AI, but tons of potential there. Why do we need AI? One of the key reasons is we have a cognitive load problem in medicine. What does that mean? People have actually studied this. They've actually said, all right, well, how many things are you juggling in your head when you make a diagnosis, for example? And people have shown that the average complex medical decision involves considering hundreds of parameters. And if you think about it, it sounds about right. Because when you're with a patient, you're going to be looking at things like signs and symptoms, medical imaging, vitals, social history, labs, family history, sleep patterns, exercise, diet, let alone the clinical evidence that you have to go through. That's a lot of things to juggle in your head. A famous psychologist named Miller from the 1950s was able to show us that the average human can process 7 ± 2 things at the same time. So that old adage of walking and chewing bubblegum at the same time, we're not that far off. We struggle with that cognitive load, and I'm sure you feel it when you're in the clinic and you've only got 5, 10 minutes with a patient and you've got a whole bunch of other patients waiting for you and you've got to juggle so much in your head. It's hard. It's very hard. What does that mean though? There's a study by the US Office of the Inspector General in the United States where they looked at Medicare and Medicaid patients, hundreds of thousands of patients. And what they were able to show is that 1 in 4 patients who were hospitalized experienced harm. 1 in 4. 1 in 8 experienced harm so significant that it resulted in a longer length of stay, resulted in permanent harm, required life-saving intervention, or the patient died. 1 in 8. And when they convened a panel of experts, they said, hey, how many of these could have been prevented? The experts reviewed a whole bunch of cases and they said, probably over 40% of them could have been prevented. So we struggle, right? What does this mean for medicine? In all facets of what we do, diagnosis, prognosis, treatment, communication, those would be the 4 big buckets that I would probably put our functions into. With diagnosis, there's lots of conditions that we have trouble with. And again, it's a matter of time. It's a matter of juggling all the different priorities that you have as a clinician. The stats are there. Studies have shown that 1 in 3 patients diagnosed with asthma, actually, they don't have asthma if you do proper spirometry and lung function tests. That's a study out of Ottawa. There's another one out in the UK. I'm going to use this example of an algorithm that was developed in Toronto, and sorry, the examples are Toronto-centric. It's just I know these a little bit better than the other examples, so I can speak to them. Parkinson's disease, 20 to 30% of patients initially diagnosed with Parkinson's are misdiagnosed. If you feed an MRI to an AI, it will misdiagnose it in less than 3% of patients. What about prognosis? Let's say you get the diagnosis right. Study after study after study has shown how poor we are at prognosis. We're just not very good at it. In fact, when we developed TartWatch, which Dr. Day had mentioned, we asked ourselves, well, this AI is supposed to predict if somebody's going to die or go to the ICU and trigger. How good are doctors? And nobody knew. Because we asked, it's comparing against you. Nobody knew. So we actually did the study. We went to the floors and we asked our doctors, nurses, and our residents, this patient that you just finished rounding on, it's not a hypothetical case. It's a real case. You just finished rounding on them, so you know them very well. Tell me if they're going to die during this hospital stay. Not a maybe or I'm not sure. They have a pulse or they don't. We collected over 3,000 clinician predictions. What we were able to show is that when a physician says this patient's going to die or go to the ICU, actually, let's focus on death. When a physician says this patient's going to die, they were right 29% of the time. The positive predictive value was 29%. And we published this. So we struggle because it's really, really hard. So at my hospital, well, where I used to work anyway, I just stepped down last week to take on a position with Ontario Health. We have an algorithm in our hemodialysis unit, which basically strings up on a regular basis all the high-risk patients who are likely to be hospitalized in the next 30 days. Because our nephrologists and our nurse practitioners in the hemodialysis unit said, I'm really struggling with trying to help these patients. I just don't have the time and energy. I don't know who the high-risk patients are. So the AI actually identifies them. There's an intensive intervention around patient education, management, and so forth. So I'm in a room with an automatic light thing, so I'm just going to be right back and turn it on. All right, great. Very annoying. Must be controlled by AI. So when they actually say, hey, I don't know who these patients are, the algorithm actually identifies them. They have these interventions. We've seen a 28% reduction in 30-day hospital admission. So again, these things actually, I think, can be pretty helpful. What about treatment? A lot of what we do in terms of treatment is trial and error. multiple sclerosis, depression. We typically have 3 out of 20 plus antidepressants that we're comfortable with. We'll try the first one. If it doesn't work, we'll call the patient back in 2 to 4 weeks. If it worked, great, you look like a hero. If not, you'll try something else. You'll try the next one. Surely we can do a better job. There are clinicians and data scientists at Princess Margaret Hospital who've developed an algorithm. It's an AI solution that develops radiation treatment plans for prostate cancer patients. Now, as you know, radiation treatment plans can be very complex, requires lots of different types of expertise, sometimes hours, if not days, to come up with a good radiation treatment plan. This does it in just under 2 minutes. And it's been shown to be in agreement 88% of the time with experts. And of course, communication. We have an orthopedic surgeon from Women's College Hospital who said, I'm really struggling because I want to help my patients, but I'm in the OR all day. I don't have time to answer their questions. And when I'm in clinic, I don't have much time with them because I've got a lot of other patients waiting. And I feel guilty when they wake up at 2 a.m. saying, is this normal? Is this a regular post-op complication? So he created a chatbot named Felix. Felix is available 24/7. And he put a lot of information that was from the hospital, his own knowledge, and all that sort of stuff. And the patients could interact with Felix at any point in time. And what he found was that 80% of patients rated it as good or excellent. And the types of questions, of course, went down, but the quality of questions improved because the chatbot would say, hey, you know what, this is okay, or no, I think you need to see your surgeon right away. So these things have been studied. Many of these are in use, which is really exciting, but they tend to be niche. You don't really see widespread use of these just yet because I think it's still starting to be socialized. We see a lot of success stories, but operationalization has been something we really struggle with. So what's the holdup? Man, these things are hard. There are a lot of challenges in deploying these things and scaling these things and making sure everyone's comfortable because it can be a little bit scary. All sorts of things to even understand what the model's doing, to have the proper bias assessments been done, to confabulations and hallucinations with generative AI. Why is that so important? Because we've seen disasters. In the United States, there were several organizations that deployed these algorithms. And of course, later on, and what the algorithms did in several of these organizations was they actually directed resources to certain types of patients. They said, these are the patients that need resources. Researchers later found that these algorithms were biased and affected millions of Black people in a negative way. So we need to be careful. There are other cases here as well. We actually see this more and more now where people are conversing with chatbots. There have been cases of suicide. This is a case in Belgium over 2 years ago, where a gentleman was chatting with ChatGPT, sorry, not ChatGPT, it was a chatbot named Eliza without any guardrails. And the conversations became really concerning. The chatbot would tell him that she loves him, the children and wife are dead. It would actually feign jealousy and love. It was really, really concerning. And he asked, would it help if I killed myself? And the chatbot said, yes, it would. So he did. We've seen teens in Florida commit suicide. There's been a couple of cases in Canada now after chatting with chatbots on Character.ai. And one would say, well, these are maybe fringe cases. If we actually think at how prevalent these things are in the youth, it's pretty alarming. There was a survey in the United States that asked youth, not have you chatted with the chatbot, but have you confided in an AI companion where you're actually really close? 73% said yes. So it's actually quite prevalent, which is concerning. This is why I think we're going to see more and more institutes like this, the Responsible AI Institute. Canada has one called CASey. And these institutes are dedicated to trying to help develop safe and deploy safe and effective algorithms. Despite the challenges, we see adoptions that are really inspiring. In the UK, for example, they've deployed an algorithm in 107 hospitals to identify stroke and determine if it can be surgically managed or medically managed. And it does this again with every CT that's done in 107 stroke centers across the UK. What they've seen is patients leaving the hospital with no or slight disability increase from 16% to 48%, as Dr. Day had alluded to. At our own hospital in Toronto, we have an algorithm that's been running for over 5 years called ChartWatch. As he had mentioned, this is an algorithm that runs on our patients every hour on the hour. Every hour on the hour, it's ingesting 150 to 170 data points, and it's predicting if the patient's going to die or go to the ICU, and it alarms our medical team. As soon as the medical team is notified, our protocols, they have to see the patient within 1 hour being paged. And again, as Dr. Day had alluded to, a 26% reduction in unexpected mortality published in the CMAJ last year. So these things are actually helping us save lives. AI scribes, this is what you're going to hear a lot about. Fun fact, the first AI scribe was actually we started creating it at Unity Health in Toronto because there was a family medicine resident, a trainee who came to us and said, this is insane how we practice medicine. This is not why I signed up for medicine. I want to focus on the patient. I don't want to focus on the EMR and computers and typing things into it. Can't a computer just listen to my conversation and generate a medical note for me? We said, that's a pretty neat idea. And of course, he ran with it. Now there's lots of companies, but it's inspiring to hear that in Alberta Health Services, you created your own. That is amazing. And that you're actually going to be deploying this province-wide. That is phenomenal. I think we can learn a lot from what you're doing in Alberta for the other provinces in the country, because I think that's really where we should be heading. And there's studies out there now supporting these. 76% of participants reported reduced cognitive load, 3 to 4 hours per week saved for primary care physicians, and over 80% saying they really want to continue using it. So what can you do? First, I think is about AI literacy and education. There's a survey by KPMG that looked at 47 countries across the globe and ranked Canada 44 out of 47 in terms of AI literacy. So it all starts with education, understanding these technologies, of how we can use them optimally, how maybe they may not work for us. The limitations are far more important to understand. So we can use them safe, responsibly, and effectively to leverage them to help us provide better care for all of us. Thank you.
Great. Thank you so much for that, Dr. Mamdani. Next, we're going to hand it over to Dr. Mike Weldon and Dr. Jake Hayward to tell us about their AHS Digital Scribe. And then after that, we'll launch into the fireside chat. So Doctors Hayward and Weldon, take it away.
Thanks a lot, Trevor, and thanks, Mohammed, for the grand overview there. It's an amazing time to be alive. Incredible things will come to us, hopefully, in the future, and we had to live through it. So I'm going to tell you a little bit of an origin story before I hand it over to Jake to discuss the grant project that we've been working on. 3 years ago, almost to the day, ChatGPT came out. It's the ChatGPT moment. This will mark history, just like many other big events. I didn't pay much attention at first, but you start to see videos come in and see what people are doing, and some amazing things could be done with language manipulation, machines imitating what humans do. One of those things was I saw someone made a poem about asthma. I was like, wow, that's neat. And I thought to myself, if you can write a poem about asthma, can you summarize a conversation about asthma? And so I put on my engineering hat and got to work. I built a prototype of a scribe that would listen to a patient conversation and summarize that. My kids were the first experimental patients, and they got sick of pretending to have asthma. But I learned that this thing could actually work. And this was a massive unlock to the point where I decided this could actually work for me for real at the emergency department, where gosh knows we need all the help that we can get. So I made a trepidatious call to the CMPA, and I asked, will I lose my license if I turn this thing on? And they gave me some guidelines. They thought about it. They said I couldn't use personal data, that I had to delete everything. Nothing could be saved, that I should inform the hospital, that I should inform the CPSA, that patients needed to consent, that I was still responsible for any mistakes. These were all very reasonable requests, but they said two other interesting things. The first was, this is an amazing technology, and we think that you should pursue it because it could make a difference. And the person on the line, I forget his name, said, if this is real, I might actually return to clinical medicine because I quit due to burnout. So I went ahead cautiously, and the rumors were true. This helped. I agree with what Dr. Mamdani said. There's huge benefits. To my efficiency, I gained maybe 10%, but that is secondary to the cognitive offload that scribing afforded me. I did not have to think about writing my notes, and I could think about my patients and their problems. And paradoxically, it made my encounters more human. So AI came to my work, and it allowed me to listen and think more about my patients. For those reasons, I would never go back. I've been using Jenkins now, our tool, for the last 3 years. I can't imagine going back to dictation or to typing notes. I hope that in the future we can leverage this technology to offload even more things and allow us to practice medicine in a human way, and the way that we all hoped that we would. So I'm very inspired by what we've done, and I'm grateful to Jake, who came into my life after I did a quick presentation at the U of A. Jake and I were able to get a grant funding to build this scribe more professionally and host it within Alberta Health Services infrastructure. This allowed us to secure the data. We can now use confidential information securely, and we've developed and deployed it from there. I'll turn it over to Jake to talk about the miracle in the making.
Yeah, for sure. Thanks, Mike. So I think, yeah, maybe we have some slides that we are going to scroll through. But the slide that you're seeing now is just the picture of like the scribe that we're using, the Jenkins scribe that we all kind of co-developed together. But yeah, as Mike mentioned, so I'm not an engineer. I'm not a computer scientist. I have some background in like cognitive systems and comp sci from undergrad, but that's about it. I haven't really coded anything significant in my life. But I think as you as you can tell, Mike's relatively inspiring. A trailblazer and a disruptor and an innovator who's also a clinician. So I think for me, AI is fascinating, but what was more motivating and inspiring to me is to try and imagine a future where physicians are empowered to change their own practices and their lives and the lives of patients. Because I think it really feels to me like you're a little locked into these technological solutions that don't necessarily ring as useful or true in your life as a clinician. And then the default is to just become really cynical and to complain and then eventually maybe to leave. That seems unfortunate because as we can see, like we all see problems and we can all imagine fixes. But there's been barriers to us to creating fixes, and that often comes down to computer coding. I found Mike, and he can do some coding, but it also is fascinating to me that now we can interact with computers through language, and I think that that is the future. So I'm really interested in how we as individual problem solvers can make our lives better and those of our patients better by using our language. But our scribe is like one example of how we might be able to create solutions. This is a pretty simple one, and there's lots that will come down in the future. So basically, I don't think we need to go through the technicalities of how a scribe works. As you can imagine, as it's already been alluded to, you take a recording, AI makes it into a clinical note. You have to review the note. We can't rely on AI for all decisions, not even the administrative ones at this level. So we need to make sure that the physicians review it. So there's a certain degree of autonomy that we can't offload. But we were funded by the CMA and Scotiabank, and then we have in-kind support from AHS to basically explore this concept of like, can we take a homegrown tech solution and make it work for our province? So you can move slides. And so far, I'd say so far so good. Like we're not a commercial provider. We don't provide enterprise solutions. To me, it's about like democratization or decentralization of artificial intelligence and seeing if physicians can interact somewhat directly with the technologies and the models themselves, because the models, the AI, the little options that you have for accessing cognition that's not your own and putting it to work, they're only expanding. But this is our little test case. And so we're grateful for the funding, but we've got a few hundred registered users now and we're expanding. We've got a lot of recordings, we've got a lot of hours of data. Physicians are in full control of that data, and so is AHS. So you're basically just asking patients to consent to data management practices that they already consent to when they come into an emerge. And so navigating a lot of those governance issues, regulation, policy, and professionalism, that's a lot of the work that we're doing in this grant and that I've been helping to lead. And there's a ton of interest, of course, for scribes. That's not really a surprise to me anymore, but I do think there's hundreds, if not thousands, of applications that are going to come down the pipeline. This is just just dipping the toe in the shallow end of a larger pool. But that's it for us, yeah.
Fantastic. Thank you for that overview. That's excellent. So we're going to launch into the next part of the session, which is the fireside chat. And I can see there's already questions popping up in the chat as well, which is fantastic. One thing to mention is if you're looking for the Q&A bar on the bottom of your Zoom screen and you don't see it, you might just have to click the circle with the three dots for more, and then the Q&A function is there. But alternatively, feel free to type your questions into the chat as others are doing. So the first question I have is for Dr. Mamdani. And so you've given us a lot of data on the outcomes and how these tools are changing the experience for patients. Can you tell us more about how the users of these tools are finding them and what their experience is like on a day-to-day basis in these acute care facilities that are using these tools?
Yeah, it's a great question. Honestly, I think it's all over the map. There are many, many AI solutions that are just horrendous. It's just really awful. And clinicians hate them and they don't use them. Then there are other solutions where the clinicians swear by them. They take them up and they're like, okay, this has fundamentally changed how I do business. Um, and I think it's largely driven by a lot of human factors considerations. Does the tool fit into the workflow? Is it actually giving you the information you need? The ones that are designed by clinicians tend to do the worst, tend to do the best, because you're really taking into consideration what the end user really needs. The technology for a lot of things is actually it's actually there. Some obviously it's not quite there yet, but for much of it it's there. It's the human factors and the change management and deployment considerations where a lot of stuff fails. So I would say I don't think there's a straight answer for it. It's all over the map, but the ones that work tend to work really, really well, and the ones that don't fail really, really badly.
And then Jake and Mike, with your experience with Jenkins rolling it out amongst emergency medicine physicians in the province, what's your experience been in terms of how the users find these tools?
I'll take the first stab at that one. So there's a group of early adopters that understand the technology and for whom their workflow is amenable to the use of a scribe. Those people are completely converted. They don't want to go back. They've realized the gains in multiple dimensions. They trust the technology enough, even though it is not perfect. And it still has amplified them, as Jake mentioned, allowed them to do more. And so that's what we're trying to replicate. Not all workflows will benefit from a scribe or AI, as Dr. Mamdani is mentioning. The trick is for us as professionals, as a profession, to find those little niches where the gains are realizable with the tools that we have available. This is such a rapidly evolving space with many commercial vendors, including Epic themselves in the market. But it's a tool that you can develop on your own and deploy that is useful today. And in the absence of great policy, the more that you can use and understand the technology and its applications, the better the policy that we can make. So I like what Jake says, let's get it in the hands of users and democratize the technology. That really resonates with me because I think as professionals, we have an obligation to understand the benefits, the pros, the cons, the side effects, the effects, and help everybody get the benefit out of this revolutionary technology.
Yeah, I obviously agree with everything Mike says. I think in a practical front, like what we're trying to learn from our project about implementation considerations, uptake. Like we really want to know what the curve looks like in a representative population. I think it's relatively common to publish studies that sort of reflect the early adopters of that curve, maybe some smaller pilot studies with some volunteer users, and they tend to be interested. Like the early part of the curve, I think misrepresents what we'll probably see as a reality. What I suspect, and of course we don't have published data or even a preliminary analysis yet, but what I suspect anecdotally is that just like any technology, the match between the technology and the user, and then the synergy is as heterogeneous as the population. And so for some people, it just resonates. It's like the way their brain works, and they'd rather review a note than write it from scratch. They don't want to dictate or speak quickly or type, and it's just been a real pain point for them in their practice. And it's just ripe for uptake, and especially for the people who are tech ready and a little bit experimental. Because you do need to generally, when you take on a new technology, there is a friction to uptake and change, just in terms of like dealing with a few shifts where you have to have some uncertainty around your workflow. And that's really hard in a pressed professional life. You don't necessarily know which day of the week you want to show up and do something new, and it's pretty much none of them. But that being said, like if you can invest in that change, what I've seen with myself is like, you do eventually you get to the other side of that hump, and I've changed some of the ways that I do my medicine, and I think for the better. Of course, I was very invested in this for various reasons, and it's hard to necessarily understand to go back to the mindset where I had no investment academically, intellectually, or otherwise in the area. But that's the general, user you're looking to really access, is the person who isn't really asking for it, but may benefit if they can actually put in a bit of time. And that's where a lot of the funding and the resources around like the implementation, the like support systems around practice change and culture change are where you get a big return on investment. Our project's not actually set up for that. We sort of make this thing available and see what happens, right? But if you can get some at the shoulder support in the emerge, like having a good buddy who's also a doctor show you how to use something, I think you're going to see a lot more people benefit than we might be seeing now. But like it'll take a few years, I think, to see the true extent of the curve.
And then there's been lots of evidence presented about like patient outcomes. And then Dr. Weldon, you made the comment about how the person at the CPSA said, "Oh, if I can use this in my practice, maybe I won't be so burnt out, and then I can come back to practice." And then Dr. Mamdani, you talked about the cognitive load that we face as physicians, the increasing complexity, the limited amount of things that we can juggle at any given time. Have you folks seen any objective data that these tools actually improve like the quality of life of physicians, or anything that suggests that it actually makes their jobs easier?
And maybe I can interject. People have actually studied cognitive load, and I believe it was an Ontario MD study actually asked physicians, "Are you able to focus more on your patients?" And had satisfaction measures as well. And yeah, actually, the majority of people said, "Absolutely, it helps me focus more on my patients." I think the percentage of physicians who reported reduced cognitive load was 76% in the Ontario MD study, and satisfaction scores were actually quite high. There's other emerging data as well from other places as well. They're basically saying the same thing. Now, these things are not perfect. For some physicians who are very, very diligent, you probably don't need it, but it might save you a lot of time. Others, it just may not be up to your level, so you may not find it that useful. But what most studies suggest is that the majority of physicians actually tend to benefit from it.
Yeah, I think that's a fair representation of the state of the literature and the research, but I think there's still a lot to come. I mean, I think there's pockets where it's going to help and pockets where it doesn't help, and it's hard. Like I'd say so based on our early experience with this, like it's not a panacea, right? Like, an AI scribe can't change the fact that there's 60 in the waiting room and I have no beds. I mean, there's got to be some ceiling effect to my work life, satisfaction. I think that, I think it's really nice to have some support. It's really nice to have a technology that isn't an annoyance on some level. It actually is helping. Maybe we're coming off of the age of the EMR introduction, which created a lot of technology cynicism. And I hope that the next wave, of course, brings people onto the technology train, and they realize that, wow, this stuff can actually make my life better. But I still think if we just measure your burnout scores, for example, I think cognitive load might be a little bit more granular, but when we're looking at our burnout scores and our surveys, I think people are still burnt out to some extent because of the environment that we work in the Emerge, and that if you give me a scribe, it's not going to change some of the things that really make my life challenging, but it's really nice. And for some people, it actually will keep them in the job. And I don't know how many that is, but if it's even one or two, I think it's probably worth it, right? Because the other ones who do benefit and use it, there's a lot of like harder to measure benefits. I can say for myself, I think my interactions with the patients are better. Like I spend more time in the room because the time in the room is time spent charting. It's the same thing. So I've just doubled the task, and I can review things verbally with patients And I know that that's going into my note. There's interesting ways that I think it changes my workflow. And I think it takes time to get used to that. And those benefits are a bit harder to measure.
Yeah, one of the interesting things about, things like ConnectCare or Epic or EMRs is often the technology forces you to change your workflow to match the technology. When an AI tool, you can actually probably reasonably integrate into your workflow and have the technology match your workflow rather than the other way around.
Mhm.
Yeah, it's really interesting. There's a lot of comments in the chat about the accuracy and hallucinations and sort of the heterogeneity of quality of output. And Dr. Hayward, you've made comments as well that it's not a panacea. It helps in some situations, not so helpful in others. So, what comments do you folks have in those situations where we have to be aware of the bias, we have to be aware of the hallucinations, and at the same time, we want to use these tools to make our clinical lives easier? What do you say to that?
I'll address it a little bit there too. So, um, at the end of the day, I'm responsible for the note. I read every one. I'm legally responsible when I push sign. So if when I edit it, there are errors in there that cause me to double back, rethink, not trust, or throw the whole thing out and start again, which does happen occasionally. If those things happen too frequently, the tool is useless. It's in my experience nowhere near that bad. I make minor edits to probably half to a third of notes. Usually they're minor. I would say 1 out of 20 notes has an error that is significant and, in my professional opinion, could affect clinical care if I did not catch that. So we can have a discussion about, whether you just get so lazy that you just push sign on everything. I don't think that will ever happen. Certainly, the liability would never go away. And then over time, there's an evolution. So we don't use ChatGPT, to be clear, for those asking. We use GPT 4o, and we do give users access to other models. So the models from Llama, Claude, and DeepSeek are available to you. We recommend that you use GPT 4o because it's the best. We have more control as well over the prompts and the guardrails that are in place to minimize errors, omissions, and hallucinations, as they're known. These are difficult things to measure precisely, as our group has found during the execution of this grant and the research work that's ongoing. But at the end of the day, you are responsible as an individual, and it's up to you to decide if the gains outweigh the costs. For me, it's no question. This is incredibly powerful technology, and I think I'm not alone. Like Epic has a scribe, and there's a number of other ones. Like there's 100 commercial scribes out there. So certainly people are getting value despite the wrinkles.
I'll just build on that. I mean, Trevor, you can tell that we could probably talk about this for an hour and we shouldn't, but I'll try and be brief. This whole area of evaluation, this other, parallel process, like part of our project is incredibly challenging. It's turning out to be extremely challenging. That's a super important realization on its own. We have a couple, we have like $1 million grant to like study this, and we're looking at the literature and we're looking at the claims from commercial providers about safety, and we're like, why is it so hard to study this? Then like, you can't find their methods. You can't figure out exactly how they define safety risk, like what was an error. How we're finding even to get consensus amongst physicians about what is a clinically relevant or clinically significant documentation error is almost an impossible task. We're trying to whittle down to like whatever we can get that's a reliable measure of safety from a note. I think in some respects, so basically that means like the premise for doing this evaluation is very challenging. How many physician hours do you have? Like how many physicians do you have who can review things and come to a consensus amongst themselves about what was an important error is very hard. I would wager no one's doing that. And that's what we can offer as a sort of third-party evaluator from an academic sense is we can say, look, we tried. We have all the data. And it's not reasonable to expect organizations to monitor safety. It's just so challenging. And we tried to automate it. We're trying to get other LLMs to judge these LLMs. And it's like, well, they can't judge themselves, right? It's circular. And so it becomes hard. And there's a limit to what organizations can do. Where does that leave you? You as a physician are responsible for your note. And that's why this is the entry road. This is the wedge for AI. It's a low risk, high frequency clinical task. It's documentation administration. And so that's where AI is going to come in first. It's like you do this very frequently. It's annoying, but the safety risk is hard to measure and it's probably low. So you have a medical student, a resident. We're very used to getting notes put in front of us that may be of questionable quality, but we have to sign off on them. And this is no different. You know, I get an AI generated note and I have to think, well, how good is my AI today? How is it good as my medical student today? At least the AI is consistent and it's getting better. Because as we see new models come in and we make, you know, we started with GPT-3 and then we say, well, now you can use, you know, now you can use Maestro, now you can use Llama, we use the open source ones, or get an agreement to use GPT-4, and then we have 4.0, and then it's going to be 5, and then it's going to be Gemini. Eventually you're like, you know, in my experience, I've done this thousands of times. This is performing better than my R3 resident. And I know it better. I've had so many interactions with it. I'm not having a new resident every day. This is the same one. I know its deficiencies. That to me is a safe situation compared to the current standard. But if you put this thing in a fully autonomous mode and you say, go do 5 tasks in a row that are going to influence patient care and outcomes and then prescribe something, we all know that we're not there yet, right? So the backstop here is physician responsibility. You have your insurance. That's why this technology even has a chance to make it to the real world. It's all about the physicians.
Sorry, Dr. Mamdani, did you want to make any comments just before I jump in?
Yeah, I mean, I think these points are bang on. And I think just one point to drive home in terms of what Dr. Hayward was saying. What is the gold standard? What's the reference? So, sometimes we actually have to ask ourselves, how good are my quality? How good are my notes? What's the quality like? How often do I see, is that really right? Is that a hallucination in terms of a human hallucinating things? I bet you're going to find it's not as small as you think. So, we need to kind of understand where we are, and because we assume AI to be 100% perfect. We want AI to be 100% perfect, but we as humans are far from that. So I think as long as it can actually offer us an advantage over how we currently perform, and what we typically see with studies is that the quality of your notes actually improves with these things. It doesn't get worse. Now, there's some physicians who write amazing notes. You're going to be better. But for most physicians, I think you'll find it actually improves.
And then, Jake, you made the comment about learners and how sometimes the AI is better than the learners. How have you folks found that learners have sort of integrated with these tools or work with these tools? Like, what are you seeing in the students and residents that are coming up? And what do they think of all of these tools that are now emerging in clinical practice?
I mean, I can provide a very quick answer to that. We don't have learners on our tool. It's just, our scope is sort of determined in partnership with AHS. And so right now, I think I'd be okay with it. I think the other day though, I thought my knee-jerk reaction to being like, well, all residents should use this. I really am having second thoughts about that. I think that AI in the educational sphere has, well, it definitely deserves some due consideration before we introduce AI just universally. So the reason I say that is just because, like, of course, we all have to be aware of the fact that automated tasks, especially in the language realm, can change the way you actually end up thinking as a person. So where are the most formative years where you're really trying to form the right neurons for actually consolidating your thoughts and synthesizing information? That's a super, super important task. And if you ever think that you're going to be able to effectively supervise AI agents in a knowledge synthesis, language synthesis task, you actually have to be able to do it. And if you've never done it, I don't think you're in a position to effectively supervise language-based cognition. And so I do think there's a forced, like, sort of vacuum moratorium on AI that is important for the years of development, the younger years of entry into a profession or younger years of schooling, because I don't think you can put someone in a junior position to supervise a bunch of AI who's really good at language, because you're just going to be taken for a spin all the time. You're like, that looks amazing. It's not always amazing. And so I personally think that people in educational or junior roles do need to go through the painful process of synthesizing data. fortunately or unfortunately, the next wave of technology that we're going to be grappling with takes the access to that type of skill set to universal and a cost of $0. Any sort of knowledge-based synthesis task is just available. But I think we have to be careful with it. So I'm more comfortable starting with physicians, less comfortable at the younger years. I don't know how you guys feel, Mike and Mohammed.
The greatest quote I heard was AI is the best tool ever invented if you want to learn something. Unfortunately, it's also the best tool ever invented if you don't want to learn anything or do any of the work yourself. So in education, the people are wrestling with this in a huge way. So you have now not just a calculator for math, you have a calculator for language and reasoning and things that we all need to learn and get good at in the ways that Jake is describing. So yeah, there are times when it is not appropriate to use it, period. And learning is one of those. But we have to wrestle with this technology and the fact that it could amplify what we can produce, especially in healthcare, where we're so desperate for every last minute of a clinician's time. So it's this funny dichotomy, honestly, in my opinion. I've taken to using it myself as a cognitive tool, but that requires discipline on the part of me. Why does this patient have COPD? Make the case. It'll make a beautiful case, and you'll be like, yeah, 100% COPD. Make the case that this patient has CHF. Oh, that's really good too. Oh my God, now I don't know which one to believe. That's what I'm going for. I'm using it to exercise my critical thought. That's what makes physicians great, because we're professionals and we do this all the time. We are going to have to employ those skills in evaluating this technology writ large. So it's a big task.
Yeah, maybe I'll just add, there's studies out there now, including a few from Microsoft, that show that extensive use of AI erodes critical thinking skills. So there is this kind of balance, right? And I get nervous about it. Just a quick story. One of the residents that we had who's rotating through St. Mike's, where we have ChartWatch up and running, went to another hospital. And the attending there, one of the physicians called me up and said, "What's this ChartWatch thing at St. Mike's?" Because my resident just asked me, like, "Where's your ChartWatch? Because I'm struggling here." Well, you should know what to do without ChartWatch. You're a clinician. It should not be what you depend on. It should be what informs you. And I think that's the best relationship right now. Unfortunately, I think we're going to get to a point where it is going to be taken up by learners. Not because we think it's the right thing to do, but that's where society may head. And just to kind of give you a quick kind of point around where things may be heading, Athena Medical actually just finished their pilots. They're going to be expanding it now, where they've integrated AI into their EMRs alongside with their AI scribe. And so the AI basically knows the patient. It knows the 5-year history of that patient in your clinic, in the hospitals, in the ecosystem. And I saw a demo 2 years ago, not recently, 2 years ago, in New Delhi, in India, where one of the physicians actually did this in his clinic. And he said, watch this. I know you guys are working on the AI scribe for a while. Watch what we've done. He's integrated into his clinical record. And he showed me a conversation with the patient. I didn't see any consent, but that's a whole other story. As he was talking to the patient, a bubble would pop up, and he goes, "I can choose to click on this bubble or I can ignore it." And he says, the AI we've integrated knows all our patients, knows the history. It also knows all the national guidelines. It knows best available evidence. We've linked it up to some form of open evidence type stuff. In the bubble, he said, I clicked on it, and he showed me the box. And the box said, based on the lab results that came in 2 weeks ago, the MRI that I found yesterday, I noticed you haven't made this diagnosis. This is something you want to consider. And if he clicks yes, it'll say, according to national guidelines, these are the tests that you may want to consider ordering. Would you like me to order them for you? Then he goes on and he says, if I say I need to write a sick note, it'll actually pop up a template and it'll write it for me. Later on, another bubble popped up and he clicked on it. And the AI said, I've noticed you've diagnosed a urinary tract infection. According to national guidelines, these are 3 antibiotics that are recommended. Your patient seems to have interacting drugs with these 2 antibiotics. This one seems to be the safest without any interacting drugs. Would you agree with this? And if you click it, it talks to the pharmacy downstairs. The prescription will be filled by the time you're done your appointment. Now, is it perfect? Don't know. Has it been vetted? Don't know. But that's where the world is heading. So what does that do? Not only for care, that sounds great, but what does it do for our critical thinking skills?
Yeah,
It's
that's
a
I should say I can't I'm not disillusioned to think that our little pilot is preventing commercial uptake. I mean, to be honest, what's preventing all of our residents from buying any scribe? Like it could be 70% penetration right now. I don't actually know. And we should all just get used to the fact that it's coming. I personally, as a project PI, don't really want to be responsible right now for interacting with the residency program around what this means because I'm like, that's important stuff. But I think as Mohammed's mentioned, like we're all gonna, I notice this all the time, day-to-day life. You're like, what parts of my brain and what parts of the future's human brain is going to be like offloaded, to some technology interface. We don't use our memory the same way we used to pre-iPhones. And in 20 years, we're not going to use our memory the same way we did pre-AI. So our role in that is yet to be determined, but it'd be pretty interesting.
So if we imagine a dystopian future where it's Terminator 2, John Connor was right all along, and the machines are stepping on all of the human skulls, what problems are doctors going to have to solve when AI is fully leveraged into medical practice? Like, do you folks foresee a situation where the AI replaces the human, and then moving forward, the practice of medicine is largely agentic?
I don't see that happening. Um, the the ethics and legal elements of AI deployments, as amazing as they promise to be, will take decades. These are going to all have to be litigated. Like the case that Mohammed describes, if there's an error somewhere in there, who's responsible for that? It's out for now, it's the doctors, period. Like that's not going to change in the short term, but slowly it will. Like when does self-driving become safer than human driving? Now, according to the more and more extensive data. That took 10 plus years for self-driving, and that's a pretty narrow use case. In medicine, we have thousands, and it's going to be a lot of work evaluating all of these things. Imagine the validation study of an AI agent.
Yeah, maybe I'll just add. I mean, I agree. I don't think agentic AI is scary, but I think we're a ways away from there because I don't think it's there yet. That being said, the rate of improvement that we're seeing is mind-boggling. Literally every few months, there's a new LLM or new version that just shocks the mind in terms of how good it is. Now, will it reach a plateau? Yeah, I bet you it will. But then quantum computing's around the corner, or so they say. And by the corner, I mean 10 years, 15 years. If we kind of start looking forward, um, I think we are going to see agentic AIs kind of slowly start to bleed in, but we have to own it. If we don't improve our literacy and if we don't understand what we want to be, I think it'll be bad for us. Um, what we're seeing in terms of the capabilities, technologies, and this is where the other thing I want to really kind of stress is confidence. We have to have confidence because there are studies now that are coming out. There was one in a small randomized trial that actually compared physicians who were given AI versus physicians who were given best available evidence. And it compared the cognitive reasoning around clinical cases that were thrown at them. And what they found was the AI plus clinician was no better than the AI plus best available evidence. So you'd say, okay, there's no reason to use AI. Well, they had a third arm that they didn't tell anyone about. It was the AI by itself, and it beat both of them,
Yeah.
right? Google's put out something just recently around their program called Amy. They finished their pilot. Actually, I think they're finished or finishing their pilot at Yale. Same thing. Humans actually made it worse. Now, that scares a lot of people, but I think those are specific cases because there will be a time where we'll say, "Am I really at worse than an AI?" No, I think we got to own this.
Yeah, it's a really interesting question. It's philosophical, it's
Yes.
metaphysical. I mean, 2 minutes to the top of the hour, not going to cover it. Uh, I'll show my human bias because, like, in the current day, I still go to work and I still think my AI tools are helpful, but kind of dumb. And someone had mentioned in the chat, exponential change and advance is hard to comprehend. I think just being on your toes these days and trying to figure out how you determine who you trust and what's important to you, what your priorities are. Like, we still have to be the barometers on trust. And no matter where the intelligent being is that I interact with, if it's a human or a machine, I ultimately have to determine if I trust it. Trust is a funny thing because it does require some what we think of maybe intangible element of being human, which is being flawed. And I've learned from I have a certain hardware based on evolution and then a certain amount of data acquisition through, as you mentioned, five senses in a lifetime. I still think there's something different about the cognitive system of a human that is not yet going to be replicated through pre-training on an internet based of data. So until there's a sort of replicable process, I think they're unique cognitive beings, and we're just getting to know a different one that's going to have strengths and weaknesses, and we have to characterize those and work with it. We're used to working only with humans, and now we're going to work with something else. I'm not going to trust it all the time, and I don't think patients are going to trust it all the time. And patients trust me, and I still leave the room after interacting with the patient multiple times in a day thinking, my gut instinct about this is based on things that my AI cannot see. It's the non-verbal cues. It's the little feelings that I have about this person interacting with their disease based on their personality and what I understand about people after years of working with people that leads me to do something clinically. And I still think that has value. People would say that's very flawed and it can cause harm, but I think it's going to have a unique contribution. The AI will be different in the way it thinks and it'll have its own weaknesses. We miss stuff, it misses stuff. You'd think synergistically we're better together because we come from different origins. That's my thought around at least the clinical side of medicine where you're talking to humans. I just have a feeling it's unique, but we'll see in 5, 10, 50 years. I don't know.
Some interesting thoughts and comments. So we have about 11 minutes left in the fireside chat, and I think we'll pull it back into the realm of the pragmatic. There's lots of questions in the chat about the practical application of these tools on sort of a day-to-day basis. So there was a good question about consent. So how do you folks navigate patient consent, like in something like an emergency department or an inpatient hospital setting?
We generated a sample consent that was sort of three sentences long that covered what we thought were the main principles of consent. Pros, cons, alternatives, ability to say no. And we gave it to HS Legal and got back at, almost 1 page consent. And this went back and forth a little bit, and we landed on something closer to what we needed it to be. We put a scripted consent in our app so that clinicians can read that off to patients. I'm trying to bring it up real quick here. I have a new AHS tool that records our conversation and uses AI to help me write my notes. I review everything before it's added to your chart. Saying no won't affect your care. Are you okay if I turn it on? I've been doing this for years, 2.5 years. It is so rare that somebody says no. And most of the time, it's whatever makes your job easier, doctor. It's always so humbling to hear that from patients, but that's the most common thing. So that's how we approach it. The college says that we need consent, and I know that they are reevaluating that based on my recent discussion with them, but for now, it's a consent. And a word on privacy, because I see that in the chat as well. So Alberta is a little bit different than Ontario. They're a little bit stricter. Ontario and BC have a list of scribes that are available for clinic use outside of the health system, so in private clinics. Alberta does not have that. My understanding is that you as a clinic provider need a PIA submitted and approved by the Office of the Information and Privacy Commissioner in order to use one of these tools. I think that's bad policy because people will use them anyways. And why not gain the efficiency and the feedback of everybody using them? Jenkins, as an example, we do have a PIA that AHS helped us do. I'm eternally grateful for that. And we are the only sanctioned tool for use inside of AHS presently.
I think I think the area of consent, as I mentioned before, governance, policy, and professionalism is like one of the most fascinating areas, because it's so far outpaced in its rate of evolution compared to the technology. I don't know how there's a hope for organizations and regulators and whatnot to even keep up at all with what's available on the front lines. So this is the crux that the organization is in. AI is being used. This is basically how we came to them, right? We said, look, this stuff's being used every day. Data is going out to multiple companies across the globe now, right? From Alberta. What do you want to do about it? And that's a physician-centric advocacy push. Like, I shouldn't be liable for this. This is a helpful technology. I should be able to use it, but I shouldn't get fined $200,000 if there's a data breach at OpenAI. The organization should support us here, as it was our feeling. But that the navigation of legal privacy, the organization, like who's taking liability for it, just look to that person for like where you need to go with your conversations and advocacy, because they take on a risk load. There's a certain level of AI literacy needed. But the amount of negotiation to get to like a reasonable consent that could be performed in the emergency department was extremely long and laborious. But at the end of the day, I don't find it to be that complicated. You know, there was already existing consent for recording a encounter. Um, and then there's like implied consent for trust in AHS with your health information. You trust that AHS will have a good relationship with Epic and that Epic in the US is going to be safe and secure. We don't consent every day verbally for that or in a written sense. And then there's other things that people assent to, like lab draws and whatnot. That whole environment just needs to get used to AI. So for us, we had the advantage that we said, your data is not leaving AHS. It's the same place as your medical record. So that just reduces the confusion. I'm not saying like, look, you have to trust Apple as well, or you have to trust OpenAI as well, or Microsoft as well. Trust AHS. So it's the notion of trust, right? Do you trust your physician? Do you trust AHS? And if people stop trusting AHS with their data, then there's a way bigger problem. And so that's why I suppose they're quite cautious with commercial tools, but this is a rapidly expanding universe of various risk potholes that people are going to have to navigate or choose to ignore, which is probably the less healthy option.
There are also questions in the chat about personalization. So, for example, if someone is using an AI scribe in clinical practice, is there a way to personalize that scribe to always remember, to speak in, or pardon me, to write in the language that the clinician would write, stuff like that? As far as you folks know, is that a component of the scribes out on market, or does it sort of depend on the vendor?
It's vendor dependent. So
Yeah.
we do not do that. Customization in Jenkins is done through prompting. So you can ask in plain English what you want and what you don't want. It works pretty well with that alone, but you have to invest in it. There was a comment about ROI. We don't train our own models either. For sure, there are vendors out there that are training on your conversations, whether that be for the production of a medical AI or for customizing the output of that AI to you as a clinician. You got to be very careful and read the fine print about where your data is going, because the CMPA and the CPSA are very clear that like under no circumstances should patient conversations or transcripts be used for training models. And yet there's definitely vendors out there that do that.
Oh yeah, this like personalization, the sort of reinforcement learning, like essentially the idea that in my workflow I should be able to train my own agent the same way I might train my own assistant is technologically possible, right? Like if I had my human scribe employee, I would expect them to get better over 3 months because I would give them little pointers along the way and say that I want you to do it this way or that way. It's technically possible to do this, and the vendors are going to be doing it. And honestly, we would love to do it. But there's a very clear stipulation in most of these like agreements that patient data, it's a minimal use policy, right? Like if I agree that you can have my personal information, you should not use it for things other than delivering my care. That's the agreement that people like AHS will sign with like Microsoft or whatever, and that we typically take on with our patients. So then if we imagine like I just collected your data and I took it to my assistant and I whatever my AI and I trained a new AI at home, it's like should the patient know that you're doing that maybe and consent to that? And so it's not a technical problem. It's, as I said, it's like this policy and legal issue. But yeah, I mean, absolutely, commercial vendors we think are doing it, but I can't comment on some of the things in the chat as well, like how does this compare to other vendors? There's so many scribes. It should indicate to you that the basic level of function of a scribe is not that hard to accomplish anymore. There's going to be levels of luxury above what we've done. And you pay at various levels for that and levels of integration. And so it's not a question of what's possible. For us, it's not about competing. We're obviously not making profits or anything. It's a question of what's the minimally viable solution to be useful. And then there's going to be a whole, smorgasbord of like options out there for people to pay whatever they want.
Fantastic. And just final question before we have to close our fireside chat this evening. So, Dr. Mamdani, you mentioned that Canada is at the bottom for AI literacy. I believe you said 40 out of 42 countries, if I remember correctly. Dr. Hayward, you mentioned that the rate of change is exponential and human brains are ill-equipped to navigate rates of exponential change. So for those of us who continue to practice and have long careers ahead of us, what advice would you have for navigating this change? And for those of us who are maybe AI naive and not sure where to dip our toe in, what advice would you have? And so, Dr. Mamdani, I'll throw it over to you, and then Dr. Weldon, Dr. Hayward, feel free to jump in thereafter.
Yeah, I think I'm just typing something into the chat. I'm going to do some shameless promotion here. It's going to start with AI literacy. I think it's going to be fundamentally important for you as a clinician to say, all right, I'm going to use a solution, but what do I have to look out for? So if it's a Gen AI solution or AI scribe, hallucinations, what even are hallucinations? What am I looking for? The frequency, the quality, both? How do I assess it? If you've got a tool that a vendor's trying to sell you, and it's a diagnostic tool, are you looking for precision and recall versus what they're going to sell you is something like AUPRC or AUC? These terms may sound foreign to you, but you're going to be taken for a ride if you don't understand them. For diagnostics, in terms of looking at rare conditions and such, you're going to look at false negatives. That's really what you want to focus on. But the vendors are going to sell you on something else. So if you're not cognizant around what these basic terminologies are, what these AI technologies can do or can't do, you're going to be in a tough spot. So education is going to be absolutely key. 44 out of 47 is what Canada ranks internationally, according to KPMG survey. TCARM, that's a center I lead at the University of Toronto. There's lots of free resources. We're a university-based center. We have a team of people who actually screen material routinely. If it was about 10 years ago, I would say, you know what, a lot of stuff out there is pretty good because there wasn't a lot of stuff out there and it was typically done by experts. But now there's a lot of material for learning. Some are great, some are not so great. So we have a team of experts that actually curates materials and says, this is what we recommend. The vast majority is free. And there's some terrific courses, no cost. There's one from Andrew Ng at Stanford, for example. If you want a certificate, it's like $100, but otherwise you can take it on Coursera. There's paid courses as well. Some are terrible, some are great, and of course, the light goes off. But there's a lot of materials here that you can go to. There are other centers as well. Learn, pick good materials, learn, and use. Do. You have a ridiculously good program here, like with Dr. Weldon and Dr. Hayward. Hats off to you for actually leading the charge on this. And I always point to the AHS example around, look, they've developed their own scribe and they've deployed it. And like, why aren't we doing this in other regions? You have leaders in your space that are offering these solutions where you can use them and get to know them and understand them. So learn and do. That's what I would say.
Yeah, oh, something's going on. I agree. I mean, I think for me, yeah, for me right now, like it's nearly impossible to keep up with the pace of change. Like if anyone follows various podcasts, there's like a million, there's not a million, there's a ton of podcasts now from people who are sort of tech forward, front of the edge, like bleeding edge folks. And it's literally impossible to keep up with tech news on a week-to-week basis Like the number of things that are changing in our lives, and this is not medicine, I'm saying in general, if we kind of want to understand what's happening with AI and energy and it's mind-blowing something. It's very hard to keep up. I don't have a solution to that, but maybe some tailored education, as Mohammed's referred to, might be helpful. Someone to like filter through some of this, because if you just go to YouTube and ask some questions, that you quickly, go down a rabbit hole and then get terrified and then get excited and then get terrified. But I will also say that, yeah, the use thing, like in day-to-day, I would say in day-to-day life, like it's hard to use this stuff in medicine because there are major barriers to the use of sensitive patient data with AI. Our project is really fundamentally trying to get physicians access to models based on the premise that if you give smart people powerful tools, they'll figure it out. Like I do have faith in the intelligence and professionalism of the medical establishment. I do. And I think that, we need to use these things because they're general purpose technologies. You're going to be like, yeah, but it's a scribe. But if I ask it to do this other thing, it will do this other thing. And the guardrails aren't quite working. And it's like a natural conversation. And where's the barriers between these things you're telling me it's for and what I could do? And you ultimately just, I think, need to interact with them. I also, use them in other parts of my life because the more you interact with AI, the more you kind of get a sense for where it's at and what it's good at and what it's bad at. That the last part of your life, I think, where you're going to adapt your AI skills to is going to be medicine. But other parts of your life, you can already start to figure out where you trust it and you don't. And then someone's going to say, oh, now you can use it in medicine. You say, okay, at least I have a general sense of what the intelligence level is. Maybe I'll get some special models that are a bit better than what I could have had. But anyway, my sense is you just have to interact with it to understand it. You can't read it from a textbook, in my mind. That's how medicine works. That's how, working with cognitive colleagues and collaborators works.
I have nothing else to add. I agree. Like this technology is sometimes called a jagged frontier, where it does things incredibly, unbelievably well that you can't even believe that you're alive to witness it, and other times it just fails, big flop. The only way to get a sense of that is to use it. So I'd recommend everybody like get a low tier subscription to Gemini, OpenAI, or Claude, Anthropic's Claude, and just use it for everything. Use it for everything. Just go, put it in there, ask your question, have your conversation. Personal, professional, everything. It's kind of incumbent on us to understand it as it comes to every profession and every facet of our lives.
Thank you for those closing comments. So Dr. Mamdani plugged his website in the chat, which is great. It's tcairem.utoronto.ca. Doctors Hayward and Weldon, there's certainly a lot of interest in Jenkins here amongst Alberta clinicians. Where can Alberta clinicians learn more about Jenkins and your project?
Mike, we should just put in some emails, don't you think? Like, I think right now the way it stands is we've sort of got a scope that was approved in the context of a grant. And so we're kind of working within that. I will say that we're slowly making headway, working with the powers that be to expand. And it's really helpful to get lots of, well, we have a lot of interest, but we're trying our best to just like expand because we certainly can. But anyway, so for people in Alberta, specifically Alberta, just email us and we can give sort of an intake process, or just meet with us. Outside of Alberta, it's not really immediately available, but we have sort of open source solutions that we imagine could be used elsewhere depending on your resources. But as an individual physician, it's a bit trickier for sure.
And what would be the best email address for you, Jake?
I put my email in the chat there. I don't mind.
Yeah.
For those in AHS facilities, there is a link that if you click on it, it says Jenkins. If you click on it, there's an email there where you can request access or more information. Currently we're limited by mostly bureaucratic reasons. So we do keep a list of interested parties and hope to expand it to all of those that are interested. And this is my favorite topic. I'm happy to answer questions about it and talk about it. I love some of the comments in the chat, and I would, wish we could have beers after to carry on the conversation. But in lieu of that, please email me.
I'm sure we could go on for another hour at least. So for those watching the recording who can't see the chat, the email addresses are michael.weldon@albertahealthservices.ca and jake.hayward, Hayward @albertahealthservices.ca, just how it's spelled on the screen right there in front of you. So just to wrap things up this evening, so thank you everyone for your time. We do have a survey that should pop up on your screen here shortly. So it's 4 questions, and we really do appreciate the feedback. We read everything you write, and we do try and integrate it into our sessions moving forward to increase the value add. So you'll see the first question pops up, and then you just scroll through all the way down, and then there's a total of 4 of them. Our next Digital Health Innovation Series will be Thursday, January 15th, 7 p.m. Mountain Time start. So we have 2 professionals who will be joining us to talk about the legal and ethical responsibilities of using AI. And I'm sure there's many rabbit holes we can go down on that session as well. So we have Dr. Christine Di Maria from the CMPA, and we have Rebecca Bromwich, who's a lawyer and legal scholar. And so they will be joining us. And so we'd love to see you there. So thank you everyone for joining us this evening. Sorry we went a little bit over time, 5 minutes. If you have any questions, any concerns, or any further feedback, feel free to email us at acttcolab@albertadoctors.org. We hope you all have a wonderful evening. Thank you.